Hello, everyone. My name is Christa Natoli. I am CTeL's Executive Director. We are so grateful to have all of you here with us today. Today's kicks off our 12 um, roundtable discussions that we will have in 2026. The first one that we are hosting is the clinical workforce shortage, continuing the conversation that we had in December. CTeL series of 12 in-person roundtable discussions will take place um, at event locations in Washington, D.C., New York, and this is the only one that will take place virtually. So we're happy that all of you have been able to make it, but please make sure that you check out our events page so you can join us in person as well for the upcoming meetings that will take place in March and April and May. With me today, I have Lydia Homovich, CTeL's Policy Analyst. Lydia and I have been working on next steps following the conversation that we had in December. So just to do a quick recap, CTeL was presented with the issue of clinical workforce shortage impacting access to healthcare services via telehealth because there were simply just not enough patients, there are simply not enough providers at bedside. So in June of 2025, when we met with HHS Office of the Secretary, we were asked to present 3 policy issues that were impacting access to healthcare services. We provided 2 traditional policy issues. One was sustainability in reimbursement under Medicare. The second was DEA waivers. And then the third, of course, was this clinical workforce shortage issue. In December of 2025, we met at the CTeL Summit and talked about how we would move forward with a public health emergency as it applies to the clinical workforce shortage. And what the members around the table decided is that it would probably, for legal and regulatory reasons, be best if we did not move forward with a public health emergency, but rather move forward with what is called a public health crisis because it doesn't have the same legal and regulatory ramifications. CTeL, between December and now, has drafted a letter to HHS Office of the Secretary to address the following issues that are listed on your screen that were highlighted in the December meeting. And that is issues impacting the clinical workforce shortage, but also impacting access to virtual care services. I'm going to turn it over to Lydia, but Lydia, I'm getting some messages that people are in our waiting room, and if you could please let them in.
I don't see anyone in the waiting room.
Okay. I will let Iris know that, but she's not in the waiting room. Okay, so Lydia, why don't we get started?
Sure. So we had sent around this letter earlier this week that we had drafted addressing some of these issues. Um, I can also include a copy of the agenda in the chat in case you would like to reference it as well. But in the meantime, um, the goal of this letter is to address the 3 domains that we talked about during our December meeting, and that is issues surrounding um, expanding the pipeline of bringing new clinicians into the clinical workforce, promoting retention of those that are already in the workforce, and addressing the biggest sources of clinician burnout that is affecting those clinicians that are both entering and in the workforce. So I'm just now going to put in the chat um, the agenda that includes the letter if you'd like to read on your own screen. But for today's meeting, for today's micro summit, we will be going through this letter together and making sure that there is consensus on the policy priorities that we are recommending to the Department of Health and Human Services. And so the letter starts out with just a basic introduction of the issue, why telehealth, digital health, and the CTeL community is playing an important role in this conversation. And the main ask, which is to urge HHS to declare a public health crisis on the national clinical workforce shortage and provide the catalyst to convene a high-level interagency coalition focused on implementing a unified national strategy. And so starting with some of the key points that we discussed during December, the first is expanding the pipeline for those entering the healthcare workforce. And the first policy priority that we included is to work with state governments and universities to remove unnecessary barriers to clinician education, such as through the advancement of virtual simulation models, to play a role in fulfilling clinical hour requirements, and also supporting the retention of clinical faculty through bolstered grants and funding opportunities. Any comments or feedback on this first policy priority for HHS?
And if you don't want to voice them, you could also put them in the chat, and I'm happy to read them and give you some cover. All right, Lydia, why don't you proceed next to the second retention?
Sure. So the next policy priority that we have suggested is to support educational curriculums that prepare healthcare workers for the future of care through the establishment of HRSA-funded grant programs, specifically for digital health residency tracks, to ensure that new graduates are proficient in telehealth, RPM, and AI-assisted diagnostics. Any comments or feedback on this policy priority? Iris?
Yeah, when you're saying residency, that implies only for physicians. Um, for a lot of people, while we do have nursing residents as a training aspect in some facilities, I think I would just want to keep it more general because I do think there's a lot of people touching telehealth right now. So if you're looking to provide proficiency, it's to all roles. It needs to be more inclusive, the language in there.
That's a good
You're only alluding to medical school right here.
that's a good point. And we'll be making edits to this in real time as well,
Thank you.
as we're going through it together.
Craig, you have your hand raised.
Sorry. It is when I see the word like proficient or proficiency, especially when we talk about training programs and ones that may be regulated or guided, because I see GME is next. Is that something that CTeL is going to then, in the next step, provide those proficiencies, or are we leaving that to the decision of the governing bodies?
Decision of governing bodies. We are offering suggestions to the administration.
Okay, thank you.
Lydia, you could proceed.
Okay. And then the last point we have, as was alluded, to work with Congress to expand GME slots, given their critical role in building the healthcare workforce by giving new medical school graduates the opportunity to complete their residency training. Feedback on this point?
Is that a term, slots? Should we use it? Is that a different term that we could use?
Positions.
will work with Congress to expand graduate medical education positions. All right, Lydia, we can keep going.
All right, and then in the retention category, we have another set of 3 policy proposals here for HHS. The first would be to promote digital health governance models that involve clinicians and allied health professionals in institutional decision making, particularly in the area of AI governance, where we have seen many health systems adopt a holistic approach that considers all stakeholders in their adoption of the technology.
I think holistic is spelled wrong.
And then the next point that we have is to work with state governments to remove administrative barriers to cross-state licensure. Licensure pathways like the Interstate Medical Licensure Compact make it easier for clinicians to provide care across state lines, but the lack of uniform adoption creates additional hurdles for clinicians. HHS should also work with state governments to create policies that allow for patients with existing patient-clinician relationships to have visits while in their home state without requiring full licensure paperwork from the clinician, as was the case that we highlighted in the state of Washington that they enacted last year. Comments or feedback on this position?
Hi, Lydia.
I liked it.
This is Micah. I think the only concern, and I think the change that has occurred since I think we put that in place in 2024, is just the overall trustworthiness that state governments have with HHS now. There certainly is a concern there. Other groups, and I'll go ahead and name them, like the ATA, have viewed this as an opportunity to try and frankly circumvent the state licensure process, and there is an active work group working on that right now within ATA.
Can you expand on that, Micah? I don't think I'm familiar with that working group.
I'll forward you the email, but basically, I've been working with Dr. Hughes out of Johns Hopkins on a couple of different issues related to this, mostly about just license portability and things like academic care or transplant medicine. The concept of creating a registry for specialist care or super specialist care, that kind of stuff. The ATA has seemed to turned a corner a little bit with respect to their focus on this, and so they have put together a work group that, among other things, does look to be trying to get rid of state-based licensure, or at least say you only have to have one license, and then it's going to be like a driver's license and it goes to every state. It's the long and the short of it is, it sounds good on paper, but you don't have the home state of a driver's license or the distant state of a driver's license having to do administrative prosecution. That's something that the locals can do under different levels. So it's a bit difficult to see where that's going to end up. It's just starting, but they feel that they have an opportunity with the current administration, and they are certainly going for it.
Thank you. Okay, Jess Easterday says perhaps being really clear about the continuity of care for established patients with known medical conditions. Where would you like us to insert that, Jess?
I was just thinking that it might make it a little clearer of what we're looking for. We're not looking necessarily to provide a new diagnosis, but we know a patient with rheumatoid arthritis is going to need a check every 3 to 6 months. And maybe they go to Florida because it's easier for their joints in the winter.
Mm-hmm. Yeah, understood. Micah, it sounds like you support that. What Jess just said.
Yeah, I think certainly doing that. I think I'm not sure that my medical board colleagues would support fully what we've done in Washington, which is basically divide up the practice of medicine into assessment, diagnosis, and treatment, and basically say for things like specialty consults and whatnot, the first two don't require a license.
Okay. All right. Lydia, you can proceed forward.
And then the last one that we have, one policy idea we have is create return to practice pathways via telehealth to develop a federal program that allows retired or semi-retired clinicians to remain active in the workforce by providing virtual mentorship, triage, and asynchronous consults.
Can I just ask how that would work, or how we're envisioning that?
Is the person that suggested this idea, are they on the call?
I think that's something that we sort of already do. At least the way I'm reading it is that provider wants to retire, but we say, okay, how about you work 3 days a week remotely or virtually, and do our on-demand video visits and our e-visits.
Mm-hmm. Right.
So, they're kind of phasing out. They're still working, but not working necessarily in their traditional practice.
Yeah, we have a guidance at the board level. I think a lot of us do, but I'll speak specifically to Washington State, where we don't call it supports. We call it practice transition, and it's just a recognition that as you age, you're dealing with other things. So I mean, the most obvious and controversial one is past a certain age, you probably shouldn't be taking call because it takes you so much longer to recover. And pediatrics is notorious for this, where if you're taking a 24 or 48 hour period, it's like 6 days before they feel back normal again, which is also incidentally where you find medical errors that occur. So practice transition relative to their own circumstances, whether it be age or health. We also have retired status licenses that many boards have, and they allow for practice in a limited capacity. Sometimes there's a compensation tag to that where you're not allowed to take compensation. You can only work like 90 days a year or something like that. I don't always recommend those. I think it's sometimes more of they want to work with like regional area medical and do voluntary roaming clinics and that sort of stuff. But yeah, I think return to practice, when people see that language, They think of they've been out of practice for a long time. They are going to need to have some sort of a reentry program, a mentor, preceptorship, maybe a mini residency. That's so in the medical board field. That's as soon as I saw that, that's what I thought.
Okay. So create practice transition pathways via telehealth. We're okay and comfortable with that language. Develop a federal program that promotes practice transition for retired or semi-retired clinicians and remaining active in the workforce by providing virtual mentorship, triage, and asynchronous consults. I'm concerned about the asynchronous consults because, let's just leave it at consults.
How are people reading the term semi-retired?
Partially retired or
it's already happened, or trying to get them back in the workforce?
We could just say part-time clinical clinicians. That way it's like less.
Yeah, I like part-time.
Okay.
Better than semi-retired.
Yeah, because it makes it sound like we have to bring them back after they haven't practiced in years.
Right.
That's scary.
Come on, dust off the medical book.
Develop, yeah. You know, you haven't been a nurse since the Clinton administration, but
develop changed. It's going to be fine.
There's been no updates, no advances.
Develop a federal program that promotes practice transition for so we want to remove the word retired for part-time clinicians. It's a question, Lydia. I'm not sure.
I think you can keep retired there because, I mean, really what you're talking about doing, in reality, is delaying retirement by retaining them in the workforce, right? And
that's what we have to say then. Develop a federal program that promotes
workforce retention by enabling practice transition for part-time or clinicians considering retirement.
That's better. Are we, just to make sure that we're sticking to our initial North Star at the beginning, Lydia, can we just go back and let's finish with this first. Does anyone have any questions here? Beth, go ahead. And Rick after that.
Thanks. Yeah, I guess my question about this last bullet is, and maybe it's just my lack of information, but developing a federal program that promotes this. I guess my question is, what is it that we think we're going to get from this? Meaning, like, I think of my healthcare organization now, I think that's already something that they already look at. How can they do something like this already? So I guess my question is, it's really just what's the real ask when we say developing a federal program to do this? What are we wanting them to do that's different than maybe some things that are already taking place at the the hospital level or healthcare system level?
I would wonder, instead of a program, and you can call it this a program, but maybe we're more talking about promoting the knowledge of this that exists already at state board levels and also in health systems. But it also can include trying to develop, yes, the guidance, but also trying to rope in the health systems and say, this is an option to increase your workforce. It'll actually cost less because they're transitioning to a lower FTE status.
So are we looking at the word endorsement and support of such programs?
Yeah, that looks good.
Personally, I thank you. I kind of like that. Appreciate it.
Okay. Rick?
Yeah, I just wanted to echo the concern about using the word semi-retired, and certainly think part-time would be better because the definitions sometimes might result in an exclusion or affect the practice.
You're right, Rick. Yeah.
But I like the idea. So,
Labor law being triggered here, right?
yeah.
We initially developed this with so the problem that was presented to us is that hospitals and health systems that were part of CTeL's network said, we don't have enough providers at bedside, let alone the ability to staff some of these digital health platforms. So if we have to choose, we have to choose at bedside. In a personal capacity, I saw that with my own healthcare provider payer, Kaiser Permanente, that sent me an SMS, a text message saying that they would no longer be able to see patients virtually, and they would have to be seen in person for specialty consult. So the reason that CTeL is being involved in this is because this ultimately impacts telehealth. Do we think that we are presenting a letter that reflects the fact that the reason CTeL is involved in this effort is because we have a clinical workforce shortage that is ultimately impacting the care bridge, which is telehealth, which is created as a tool to provide care to patients who are in low access areas. But if we don't have enough clinicians to staff those efforts, we can't use telehealth. Do we still think that that is coming through with this letter? And maybe we go back up to the beginning to make sure that we reflect that properly at the start, and maybe we have to put some content at below.
So, Christa, this is Beth again. I'm just kind of paraphrasing a little bit to make sure I'm understanding your comment. Is your fear is that what I hear you saying is that some organizations are saying we can't do virtual because they don't have enough to even do in person.
Mm-hmm.
Wow. Okay. And I'm sorry, the wow is just like, I thought virtual was to help when they don't have enough in person. That's where I'm finding that kind of interesting.
Yeah, so there's a hospital I cannot mention, but it's in the South. It's a very large health system, and they don't even have, they came to us first saying, we don't have it. First of all, we have a large bed hospital that is only running at 50% capacity because we don't have enough nurses and clinical and doctors to staff those beds. So when we say we're out of beds, we're really saying that we're out of
Staff.
beds that could have clinical staff care for those patients in those beds. And I said, well, how is telehealth able to be used? And they said, well, no, because two problems. One, we don't have enough. They kept saying nurses. They kept saying we don't have enough nurses at bedside to take care of the patients. And when we give our clinical teams options to do virtual, they're going to choose virtual. And then we lose providers at bedside again. So there's almost an internal they're disincentivizing virtual because they can't even get those nurses at bedside. I bring this up because I want to make sure that politically, CTeL wants to focus on issues that fall within our wheelhouse, and that is clinical. The only reason we're addressing clinical workforce shortage is because it was brought to our attention that now telehealth is being impacted, and that the bridge that was typically used to provide care to patients, we don't have enough clinical staff for it. So that's a long-winded way of saying, are we conveying that point in this letter and in the beginning, and then probably have to re-summarize it in the end?
Well, I think a lot of health systems tried to supplement with contracted physicians from outside their health system to cover. That adds extra expense. It's adding workforce, but it doesn't necessarily, your bedside staff still need to be there. So yeah.
But they're still pulling from the same pool. Like that's like a lot of the data, there's not
Yeah.
There's not a, you could have Teladoc and American Well, but Teladoc and
Mhm.
American Well are still pulling from that same hypothetically
And they
100%.
do, by the way, yes.
Yeah, they do.
So it's not like Teladoc has their own and American Well has their own. I mean, we still
So,
have.
I'm thinking like we're talking about support here. So the word support needs to show up there. I think support of work, the bedside, I don't know if we want to say bedside, some other way of showing that we can relieve some of the, and I hate to use the word tasks too, but the truth of the matter is the only way we really help them remotely is by relieving them of particular tasks and allowing them to work at the top of their license for what must be done in person. And we need to differentiate that so we're not trying to say it solves the problem of the physical being at the bedside.
So do we do insufficient bedside nurses
I don't think it's just nurses though. I mean,
or
so, well, nurses,
insufficient
yeah.
and allied staff or
And now, yeah, I mean, it's everything. It's across the board these days, right? I think somebody who is not in the know, I would hope, I'll leave that to my own comments, but you would need to actually explain, let's just say it's the general public that it's not a replacement, but it's in lieu of replacement, it's a support. We need to make that really clear somehow. And I think that word support goes a long way because also if I'm looking at this from a nursing organization standpoint, I'm going to say, you know, this is not solving the problem. And, we have those staffing ratios that have to be met. And it may or may not change that depending on what those tasks are. So
Iris, I want to get back to to the main point. Our North Star is the fact that the problem is we don't have enough clinical providers in this bucket. And because we don't have enough clinical providers in this bucket, we don't have enough providers that could go in bucket 2, which is telehealth bucket. So we really can't, if we're drawing from this bucket for bedside and then also for telehealth, we just simply don't have enough. And so telehealth can't be used as a bridge anymore or a way to supplement because there's simply just not enough. And we need to bring that to the attention of the administration. Lisa,
so I think that's the word extending. I think using the word extending might help a little there.
Where would you like that? Many hospitals and health systems.
This care reversal is due to insufficient bedside nurses. However, we can extend workforce viability through the use of telehealth, something like that.
But we can't because there's not, ideally, yes, but we can't because there's not
we
enough.
Can't, yeah, the problem is we can't use the word retire. Or people get hurt and they can't physically, and we lose them completely because we don't give them that option. I mean, I don't know.
do we look at this like from a virtual nursing standpoint where bedside nurses can still continue to perform duties, tasks such as admission, discharge, transfers, monitoring, video monitoring? Do we have to get that descriptive?
We probably don't need however we extend workforce viability through telehealth because
then get rid of it.
Above it just says that we can't do that because we don't have enough. The big problem is we don't have enough providers. We're asking HHS to address the fact that we have a clinical workforce shortage and to declare this a crisis. So a coalition of interagency professionals within the government could figure out a way to expand workforce so that telehealth could still be an option to provide and expand access to care. Bev, I think you've had your hand raised, and Craig, and thanks for raising your hands, everyone, but you could also just speak up too. Bev, go ahead. Bev Malone. Beverly Malone. I think you're on mute. All right, Craig, we'll go with you next.
Is the shortage because there's not enough people, or are we asking that, or are we saying there's a shortage because of the way things have been designed, causing a functional shortage versus a real shortage? Because the points we're saying earlier were below, I can't remember where in the document this is, basically say, look, we need the federal government to come up with programs, plans, and allow for interstate licensure, not because we say there are too few, though I think we can agree it is perceived that way depending on where you are. What we're saying is that the numbers of people we have are not in the right places, and via telehealth, we can get them in the right places, but it is such a convoluted, impossible process that there just aren't enough people to do it. So, you talk about an organization, they can contract and do virtual like someone else had mentioned. So there are enough people to do virtual. They're just not able to provide the care where it's needed because of the bureaucracy of the system, which we're asking them to reduce.
Do you think that's properly reflected in the letter, or do you think that we should make some edits here?
So clinical workforce shortage, yes. Increasing limited telehealth care delivery, maybe. Telehealth was designed to bridge gaps, yes. It depends on adequate staffing. It depends upon adequate access to appropriate staff, and I don't know how to word that. There are a lot of other super bright people here that have better vocabulary than I do. I don't think it depends on having enough clinical people there. I think it's having access to enough clinical people. Right? Jessica said allocation of clinical staffing. And yes, many hospitals, health systems prioritize bedside over virtual due to insufficient bedside teams. Yes, 100%. Constraining telehealth's ability to expand access. I would say the constraint is, and I don't know a better word to use, again, much smarter folks, the limitation to expand telehealth access is not because you don't have enough on-site people. It's simply because the people that can do telehealth can't get there. There are so many rate limiting steps. And to Micah's point about and we've all got interstate licensure, Alabama probably needs physicians. They probably need critical care doctors. I can't go see a patient in Alabama unless I have a license, and that's going to take me, it's such a bureaucratic process. So it's not that they don't have people there, it's that they can't get access to the people. I don't know if that makes any sense. Sorry.
No, it does, because there's issues like network adequacy caps that say that you could only use a certain arbitrary percentage to supplement for your network. That makes sense, but I still think we have to be very black and white and clear with a singular request. That does best with policymakers.
Right.
So the problem is we don't have enough providers. Because we don't have enough providers, telehealth is not being able to be utilized to its fullest capacity because we don't have enough providers to staff this operation, the telehealth operations. And because of that, patients are not going to be able to receive access to care in ways that are efficient for these patient populations.
So then are we saying what you just said? We're saying we don't have enough people, therefore we can't do on-site care, and we have to prioritize on-site over virtual. And we also therefore cannot do virtual care because we don't have enough people. Yet we're asking them to not only create more people, we're asking them to allow more people to get to the right place. And I don't know if we're saying that. I guess that's my...
I think you're getting into a dangerous area here. I think you could perhaps address some of the reasons for the shortages, which isn't just that there's not enough people, it's that people are leaving the field sooner than they once did. because of burnout. And one of the reasons for burnout is an overabundance of needs for certain tasks that could be taken on by a workforce that is ready to leave the physical. And again, with avoiding the word retire, we avoid explaining, or people who have, a physical disability but have the capacity to provide the knowledge and resources. You have to marry that up somehow because otherwise you can't make the argument. To what Craig was saying, we're just if there and what you're saying is if there's nobody, there's nobody. So what are they going to do with that? Then you have to increase education programs and churn out more of these people. Well, how do you do that? And does telehealth play a part in that in any way? So via the education, the knowledge, there's a huge knowledge pool there that can be leveraged. So maybe that's a way of selling it. Otherwise, you're just going in circles, I think.
Mm-hmm.
I mean, you could list it can, allowing how we say reduce windshield time, like telehealth allows reduction in windshield time for the active provider, any active provider, allowing for those tasks that can be done via telehealth improves QOL, right? Quality of life, and improves efficiency when they have to be at the bedside and would in turn decrease burnout and extend the workforce.
As you're typing, Christa, my point was only that the global purpose of this is to endorse and empower telehealth.
Mm-hmm.
And taking kind of, and I'll always take kind of the antagonist side, which is, does this read like, hey, look, you just need to increase bodies and all problems will be solved, as opposed to increasing the ability and access to do telehealth? And I think, Iris, if I hear kind of what you're saying, is perhaps calling out the idea that, look, we all agree there's not enough people. We not only need to increase the number of people, we need to
make their work easier,
make their work easier, make access to being involved with telehealth easier, and allow for people that are leaving the industry for the variety of reasons to remain the knowledge experts and share that knowledge. So telehealth improves its quality of life, reduces the burnout, therefore actually increasing the functional pool of people you have to continue providing care past, and I'll say it, you all can word it, past the age of retirement and past the age of burnout.
Thank you, Craig.
Do we want to, retirement is 65. Do we want to just say provide care beyond, Rick, this is a question for you, past the age of 6, or do we not want to
No.
Yeah. I don't think you want to get into.
Don't call it age.
Okay. Well, retirement was a no-no, so I wasn't sure if there was a better.
No.
I know California and Maryland use the term emeritus, and they have programs where those who are suffering from burnout or just want to decrease the workload that they've been encountering may want to find a new way to practice in a more fulfilling way. And I think it's as much a matter of mobilizing the people that now can do that. I mean, we have 2 interstate compacts for nurses and doctors that both have about 45 states at the table. So we almost have the capability to do this throughout all 50 states. And I think we can use those reciprocal opportunities that we didn't have before and develop programs. And I think the instigating this and implementing it is probably the major problem. I think we now have some bureaucratic solutions. It doesn't solve all the problems, but it's now possible to get licenses in almost every state if you wanted to do it. So how do we interest people in mobilizing the people that are out, the doctors and nurses that are out there to find ways to continue to practice in a different way?
Okay. Taking your word emeritus, Lydia, the sentence that you're currently in right now, increasing the functional pool of workers who are able to provide care past clinical emeritus status.
It avoids retirement or that term.
Someone's gonna be like, well, what is emeritus status? Are they
Yeah,
academic?
well, that's true. That's true. But I think part-time conveys what we are getting at, perhaps somebody who may not be working a full schedule for
Mhm.
various reasons.
Lisa?
Yes, hi. Sorry, I was joining late due to kind of a clash of meetings here. So sorry if this was already answered. So I was looking at this first paragraph and a couple of questions. One, when we're saying clinical workforce shortage, are we referring to hospital workforce or in general? Because how it's not clearly defined here, and we jump to second sentence there talking about hospitals and health systems. So I'm trying to understand if this is supposed to be a general clinical workforce, or are we talking about just the hospital workforce? And if so, we probably need to make that a little clearer in that first sentence. The second question or comment that I have has to do with the premise here of saying that the the shortage is affecting telehealth, and so having to use the workforce in the hospitals as opposed to telehealth. But I'm not 100% sure that is the case. And it's more that from what I have seen is that the workforce is limited on site and they're using telehealth to supplement the gaps in the limitations of the number of staff available in the hospital on site. So I actually am seeing the opposite.
Mm.
So I'm kind of so those are my two first line comments. I don't know if this was probably discussed before and you guys landed here, but just wanted to point that out.
Okay. Uh, so Lisa, that's actually interesting. So it sounds like it's the same issue, clinical workforce, but one hospital is choosing to have essentially less patients at bedside and reaching out more to their chronic condition patients that could potentially end up in the emergency room. And so they're using more telehealth, where other hospitals, depending on need, are saying, no, we can't afford to do that. We have to have patients at bedside. So it sounds like it's the same problem. Hospitals are just one hospital. It's just a
It's,
difference in
yeah, they
handling.
might handle the workforce differently. Yes. So I
Mm.
just feel, so maybe we need to adjust that sentence to be a little, more aligned with what we just said, because it just makes it sound like this is just it's a one-way issue
Mhm.
where it's really dependent on the hospital needs, resources, patient population that you're serving. And so if we're talking about hospital-based patient care, that's one thing. But if we're talking about pre-hospital or post-acute care, that's a whole other thing. So we
So
just need to.
right. And so as we're thinking about this, do we want to remove the word hospital and just put clinical workforce?
Yes.
Yeah.
Okay.
Yes.
And then maybe just say healthcare organizations or healthcare services or something like that.
Good call out. I agree.
Okay.
Okay, so it now reads nonprofit. Okay, we write to express concern that the clinical workforce shortage is increasingly limiting telehealth delivery. Telehealth was designed to help bridge gaps between patients and providers, but it depends on adequate allocation of clinical staff. Many healthcare organizations must prioritize bedside care. Should we put bedside care in quotes so they know?
So I will share with you that both the Society of Critical Care Medicine and the American Association of Critical Care Nurses, and I believe ATA also, I don't know, they're what they're doing, but they're all moving to use the term on-site and remote.
Okay.
Yeah, so that on-site could be anywhere. Could be in
Okay.
the clinic, could be in the hospital.
And they're not using so you're suggesting use the term on-site care
Yeah,
versus
on-site care.
remote
Yeah.
/ virtual?
Yes, you could, yeah, those are interchangeable, but the on-site as opposed to bedside because patients are not always in a bed,
Yeah.
they're
Do we want to say many healthcare organizations must prioritize on-site care over virtual care due to insufficient on-site staff, and then in parentheses put nurses, physicians, and allied health professionals, on-site clinical staff?
Yes.
Okay. Do we want to put the term clinical ahead of it, or is that limiting?
So is it necessarily insufficient on-site staff or just insufficient clinical staff, period? Because we already established that we have an issue on both sides of the camera.
Okay, so we remove the word on-site before clinical, Lydia. Okay. Constraining TEL's ability to expand access for the active clinician, allowing for tasks that can be done via tel to be done via tel. We have to clean that sentence up. Can we say that better for the active clinician? I don't know if a HHS employee is going to understand what that means.
Wouldn't we just say for the practicing clinician?
Yeah, that's better. So for the practicing clinician, allowing for tasks to be done via telehealth leads to better quality of life. That's not necessarily allowing for. When we say allowing for tasks to be done.
Can you help me understand why do we need to make this point right here in the opening? Is
Yeah, I don't think
this
we do, actually. I'm reading it. So
okay?
practicing clinicians, allowing the task to be done via telehealth leads to better quality of life. That seems that it's misplaced. And maybe just, what are your thoughts? Iris, I know that you wanted, and maybe Beth or someone else that was on the call, Craig, suggested that but maybe we put that lower in the paragraph, when we're talking about burnout. It seems like we address it in the bullet points. So we might not need to put it here. What are your thoughts? I don't want to remove something if you feel strongly about it, Iris or Beth.
Well, I'm trying to see what we're talking about specifically, and I've lost my ability to see the document. I'm only seeing a gallery view right now. I can't seem to get out of it.
Oh, okay. It's the.
Whoa.
Oh, I only see gallery view too. Okay, we're starting again.
Oh, there we go.
Last sentence, first paragraph.
Last sentence, first paragraph. Constraint tells For the present clinician, whatever has to be done via telehealth leads to better quality of life, reduce burnout, increasing the functional pool of workers who are able to provide care beyond full-time. So what, and your question is,
It doesn't seem to belong there. Hey Iris, it doesn't seem to belong there because it's like we're establishing that organizations are prioritizing the on-site care, but then we're jumping to the clinicians' options for workforce. But are we? I think we
well,
need to tie up what yes, they're prioritizing on-site care, but and then what's the result? What is the result of that? It kind of needs to
the reason it was
pose
there
that
was
thought.
to
Mhm.
explain the burnout portion of that as a major contributor to a decrease in the workforce, because we do have a lot of young, and I don't know, I mean, it could go anywhere, but I think it's an important point, um, because that's a large reason that people are leaving the field much sooner, even after going through all of the training. So
I
I don't
absolutely
know
agree.
where it belongs, but I think the thought
Right.
belongs in there somewhere.
Yeah, I was just in the flow of the
Mm-hmm.
thought. It just seemed to come out of nowhere because we're talking about the healthcare organization prioritizing on-site. But what does that result in? It feels like it needs a finishing thought. So
Yeah, so let's
yeah,
remove
that's
that.
all I'm saying. Mhm.
So
Yeah.
on that, what I'm seeing, well, before it got deleted, um, I think I understand what we're saying is there are tools that can help with this, but we have to make sure that HHS, i.e. CMS, is allowing for the use of this, not just allowing, but maybe promoting it. And the other thing that I would bring to that conversation, I know that we're focusing on telehealth, but we also have AI as a focus. And we're starting to see studies come out that folks that have AI assistance tools like scribes, um, chart records reviews, and summarization and that sort of thing are starting to experience less burnout as they go through their careers. So I don't know if we want to add in that into the mix as far as a portion of our argument, but we are starting to see data on that.
CTeL has another presentation that we have to give at 3 o'clock, so we have to tie this conversation up. We could always have a follow-up if you'd like, or what we could do is we could send this out to you in a Google Docs, and if anybody wants to make changes to it, you can go ahead and do that. So Lydia, how about that? Because we're a little over time right now, we appreciate everybody's contributions. We'll send an email out via Google Docs or some type of shared drive. You can
Good.
make edits via track changes. And then our goal, just so we could expectation set, is by the middle of March, we want to be able to send this out to HHS. Also, if anyone hasn't seen, all of CTeL's efforts have resulted in JD Vance actually talking about telehealth and the clinical workforce shortage. Lisa Mae Williams flagged that for me today. He is on a speaking route in Wisconsin, and so that is a direct result of CTeL working very closely with this administration to make this part of the dialogue. So thank you for everyone's great work in supporting this effort, but it has made its way to the office of the vice president. So pretty big deal for such a small organization. And but that speaks to all of the credibility of the people that are on this call. So thank you for your hard work.
Thank you.
All right. Take care.
Thanks.
Bye-bye.
Bye.
Take care, everyone.
Bye-bye.
Bye.